Hello students. Welcome to the chapter Assessment of the Musculoskeletal System. We are going to review, these are the key terms that I want you to focus, okay? These are the key terms I want you to focus. Arthritis, arthroscopy, bursitis, gout, kyphosis, lordosis, muscular dystrophy, neurovascular assessment, osteoblast, osteoclasts, osteomalacia, osteopenia, osteoporosis, scoliosis. Basically, what we are going to talk is about the mobility, sensory perception, and pain as the most important concepts in this chapter. The musculoskeletal system is the second largest body system because the first one obviously is the skin, right? It includes the bones, joints, and skeletal muscles as well as the supporting structures needed to move. Prolonged immobility can lead to skin breakdown, constipation, joint contractures, and venous thromboembolism. And this is one of the most important concepts. That's good to know, because we don't want our patients to be in the state of prolonged immobility. That is going to bring a lot of consequences like muscular dystrophy, also skin breakdown, pressure ulcers, right, which is a no-no in the hospital. Constipation, we can lead to a paralytic ileus. Paralytic ileus can cause a death. Joint contractures and venous thromboembolism also can lead to death. Okay, so we want to prevent immobility at all. Anatomy and physiology review. So for this, I'm gonna present a video. The videos in this chapter are going to be crucial to understand, and I want you to enjoy this video. It's very good.
The human skeleton gives the body its shape and provides physical support for the systems contained within. It also forms part of the musculoskeletal system that enables us to move. The structure of bone is optimized so that it is strong but relatively lightweight. The interior of bone is composed of bone marrow. It is surrounded by two major types of bone tissue: cortical bone, or the hard outer shell of bone, and trabecular bone, the spongy-looking center. The amount of each type of tissue in bone is dependent on the function of that bone. The basic unit of cortical or compact bone is the osteon. It is composed of successive concentric lamellae. This structure contributes to bone strength by resisting bending. Cells called osteocytes are distributed within the concentric lamellae. Osteocytes form a complex network that is thought to be important in maintaining the viability and structural integrity of bone. At the center of the osteon is the Haversian canal. These canals contain blood vessels and nerves. The blood vessels within bone facilitate the exchange between osteocytes and the blood. Trabecular bone is present in the interior of some bones and resists compression. Osteocytes are also contained within its structure and again play an important role in sensing local changes in strain. Trabeculae are covered in a layer of flattened lining cells that are thought to be involved in the dynamic process by which bone is formed and broken down. Bone marrow is found within the interior of bones. The surrounding trabeculae and vascular network provide structural support, nutrition, and a waste removal system for the heterogeneous group of cells found within this space. Bone marrow is a site for hematopoiesis, the process by which the cellular components of blood are formed.
Thank you so much. This was a great video. So whenever we see somebody and we see that the patient is having problems with mobility, we are not only going to think about the lack of exercise or maybe that the patient is aging and there's nothing to be done. We have to remember, right, that inside the bone is the nervation system, which is the venous, and the arteries that are inside of the bone. So to start with any recovery, we need to think about the nutrients that the patient is eating, supplements, and how those nutrients are going to travel through that nervation system and how they are going to feed the trabecular, the cortisol bone, and the bone marrow itself in order to produce good cells for the body and good cells for the bone itself. So when we see somebody having problems with mobility, that's the way we need to think, how we can cooperate with that patient in order to get the patient with proper nutrients besides the exercises and the strengthening therapy that the patient can go through. Okay, so this was an excellent video. So we know that the bones can be classified into two ways, the shape and by the structure. For example, long bones, such as the femur, are cylindric with rounded ends and often bear weight. Short bones, such as phalanges, are small and bear little or no weight. And then the other way of classification is by structure of composition. The outer layer of the bone or cortex is composed of dense, compact bone tissue. The inner layer in the medulla contains spongy cancellous tissue. The structural unit of the cortical compact bone is the nervation system that we just spoke about. A complex canal network containing microscopic blood vessels that supply nutrients and oxygen to bone and lacunae, which are small cavities that house osteocytes, the bone cells. The softer cancellous tissue contains large spaces or trabeculae, which are filled with red and yellow marrow, and hematopoiesis, production of blood cells, occurs in the red marrow with the supporting of the nutrients coming from the nervation system. Okay, the bone is not going to produce healthy blood cells if we don't support that production with proper nutrients. The yellow marrow contains fat cells. This is very important. The yellow marrow contains fat cells which can be dislodged and enter the bloodstream to cause fat embolism syndrome. We study about this in the spinal cord section. Fat embolism syndrome. And I want you all of you who want to become ER nurses, ICU nurses, needs to be familiar. Even you guys that are going to work in the rehab unit, post fracture surgery, post hip replacement, knee replacement, you need to know this, okay? Fat embolism syndrome is a life-threatening complication, and we are going to watch a video of fat embolism to understand much better, and this is coming in the NCLEX.
Fat embolism. The fat embolism can occur when the fat globules are released from the bone, usually during long bone fracture, and these fat globules can travel to the lung and obstruct the pulmonary vessels. It can also occur during reaming of the intramedullary canal. These fat globules also cause the release of inflammatory mediators, which cause endothelial lung damage and hypoxemia. Fat embolism usually occurs in trauma patients with multiple fractures, especially the fractures that involve the pelvis and the long bones. Fat embolism occurs more with closed fractures. The fat globules also may travel to the brain, and it is called cerebral embolism. It may also travel to the skin capillaries. So a trauma patient with fracture of a long bone, usually the femur, and between 1 to 3 days will develop fat embolism. This is the classic triad for that patient. Number 1, respiratory change. The fat globules affect the pulmonary vessels, so the patient will have difficulty in breathing, will have dyspnea, hypoxia. So you see this from the history and from the physical examination of the patient and from the vital signs. Patient also may have neurologic signs because the fat globules can go to the brain. So the patient may have confusion, alteration of the mental status, and in severe cases, the patient may get seizures. And then the third one is rash, petechial rash, because the fat globules can affect the dermal capillaries. Diagnosis, the history is important. The patient will have a long bone fracture. The condition usually occurs 1 to 3 days after the fracture, and you will have the classic triad: the respiratory problems, the neurological problems, and the rash. The mortality rate involving fat embolism is about 10%. Fat embolism usually occurs earlier than DVT. Which patient is at risk for fat embolism? Patient with femur fracture, patient that has non-operative treatment. If you overream the fractures, patient with pathological fracture, especially in bilateral femur fractures. Try not to fix bilateral pathological femur fractures in the same setting. Multiple trauma patients are always at risk of fat embolism. There are some diagnostic criteria established for fat embolism, and it is really a diagnosis of exclusion. So you need to have one of these major signs: respiratory, shortness of breath, hypoxemia, the oxygen saturation is less than 60 millimeter mercury, pulmonary edema, the neurological confusion, agitation, altered mental status, drowsiness, petechial rash, axilla conjunctiva, palate. Rash occurs in about 20 to 50% of cases. It usually appears within 36 hours, and it is self-limited, usually disappears in about 7 days. What are the minor signs? Tachycardia, pyrexia, anemia, thrombocytopenia, fat in the urine. You need 4 minor signs and 1 major sign for the diagnosis of fat embolism. Early stabilization of long bone fractures will reduce the risk of fat embolism. Treatment of fat embolism, you need to have a high index of suspicion for the diagnosis. The treatment is usually supportive oxygen, and in severe cases, you will do mechanical ventilation with high levels of PEEP. The outcome of the patient post-fat embolism depends on the pre-injury condition of the heart and the lungs. Thank you very much. I hope that was helpful.
It was really helpful, Dr. Nabil. So I am going to keep in mind the last sentence. The prognosis of fat embolism depends on the precondition of the heart and the lungs. So if this is occurring with with fractures in the lung bones. Think about the patients that are elderly. Think about our children, our young patients that are right now riding scooters, the bicycles, these motors, bicycles with electric motor, this and that. Also think about the obese patients. If they get a fracture, the number of fat cells are going to be bigger. That's why also if there is an obese patient, his heart, the heart of the obese patient, and the respiratory status is going to be compromised already, right? So think about all these patients. I am trying to cover these important topics extensively because whenever you work in a hospital, you need to pay attention to this. Okay, and these are very important. Okay, so we spoke about this. Then we have here a graphic, a structure of a typical long bone. You can see the diaphysis is the long part. Then you have the epiphysis, which is at the end of the bone. We can see the Harvasian system. Now, we are going to talk the musculoskeletal differences in selected ethnic groups. And this is good to know. This table here is good to know. So black people, black patients, they have a greater bone density than whites. Asian, Pacific Islanders, and Hispanics accounts for decreased incidence of osteoporosis. God bless them. Black people, greater bone density, decreased incidence of osteoporosis. As I said, that's good to know. African Americans usually have more bone mass when compared to other races, which makes them at decreased risk for osteoporosis. And white women tend to have the least amount of bone density. I'm going to repeat. White women tend to have the least amount of bone density in any group, which makes them more likely to have osteoporosis and fractures. So African American, more bone mass, white woman, least amount of bone density. That is good to know, necessary to know. So the Chinese Americans, they have bones shorter or smaller with less bone density, increased incidence of osteoporosis. And then we have also the Amish. The Amish, they have greater incidence of dwarfism. What is dwarfism, Dr. Matalana? So it's a short stature. Irish American, they have less bone density than black. And that's good to know too. Okay, function of the skeletal system. We know that provides framework, supports the surrounding tissues, assists in movement, protect vital organs such as heart and the lungs. I'm talking about the sternum. But the most important for us would be manufactures blood vessels in red bone marrow and provides storage of mineral salts. Example of this is calcium and phosphorus. So manufacture blood cells and provides storage for mineral calcium and phosphorus. Okay, so the bones undergoes a continued process of formation and resorption. Resorption is not the same as absorption. Resorption means losing cells. Bone resorption is losing cells. So, or destruction at equal rates until the age of 35 years. So you have process of cells, resorption, destruction, right? Production, destruction, production, destruction. In later years, after 35 years, bone resorption increases, meaning there is more destruction, decreasing bone mass and predisposing patients to injury, especially older women. Okay, so then we have the bone accounts for about 99% of calcium in the body and 90% of the phosphorus. 99 of calcium and 90 of phosphorus. That's the That's the main composition of the bone. In healthy adults, the serum concentration of calcium and phosphorus maintain an inverse relationship. So we are talking about two different areas. We are talking about the bone composition, which is 99% calcium and 90% phosphorus. And the serum component is when these cells are entering the bloodstream. Okay, so the serum concentration of calcium and phosphorus maintain an inverse relationship. Is in the serum, the inverse relationship is not in the bone. Okay, meaning when the calcium is high, the phosphorus is going to be low. If the phosphorus is high, calcium in serum is going to be low. That's the inverse relationship. When serum levels are altered, calcitonin and parathyroid hormone work to maintain equilibrium. When serum levels are altered, meaning the calcium and phosphorus are altered, are not in balance, calcitonin and parathyroid hormone work to maintain the equilibrium. If the calcium in the blood is decreased, the bone, which stores calcium, releases calcium into the bloodstream in response to PTH stimulation. This concept right here, these three lines are kind of confusing for some students. I'm going to try to make it easier. I'm going to try to break it down. So calcitonin, the way I remember this, the way I used to study calcitonin is, first of all, calcitonin is produced by the thyroid, by the C cells in the thyroid. Okay, calcitonin, start with the C, is produced by the C cells in the thyroid. Number one. Number two, calcitonin, look at the word, calcium to non-increase. That's the way I remember. Calcium, to non-increase. Meaning, calcitonin is going to decrease the abnormal high levels of calcium. Calcitonin, calcium to non-increase. Okay, that's the way I remember. Parathyroid, PTH, for me is put that thing, meaning increase the calcium, put that thing. I remember that way. So let's review this again. When serum levels are altered, okay, it could be phosphorus or calcium, and we know in the serum they are having an inverse relationship. Calcitonin and parathyroid work to maintain equilibrium. So far, okay. If the calcium in the blood is decreased, the bone which stores the calcium, the bone which is our saving account of calcium and phosphorus, release calcium into the bloodstream in response to put that thing stimulation. So if the calcium is low, the PTH, put that thing, is gonna make the bone to release calcium. Calcitonin, calcium to non-increase, is produced by, there you go, by the thyroid glands and decrease the serum calcium concentration if it is increased above its normal level. So calcitonin is going to inhibit bone resorption. Calcitonin, calcium to non-increase, is going to inhibit bone resorption, is going to stop bone destruction, bone resorption, bone destruction, bone loss, and increases renal excretion of calcium and phosphorus as needed to maintain balance in the body. So calcitonin is going to reduce calcium to non-increase, is going to reduce the calcium in the serum by telling the bone stop the destruction, and is gonna give the order to the kidneys, increase renal excretion, get rid of that calcium, and is going to maybe increase the level of phosphorus. Remember, there is a inverse relationship to maintain the body balance. Okay, Let's remember our calcium in serum normal levels are 9 to 10.5 and phosphorus is 3 to 4.5. Vitamin D and its metabolites are produced in the body and transported in the blood to promote the absorption of calcium and phosphorus from the small intestine. Okay, they also seem to enhance PTH activity. Vitamin D is going to enhance PTH activity, put that thing to release calcium from the bone. Okay, a decrease in the body's vitamin D level can result in osteomyelitis, which is the softening of the bone in the adult. A decrease of vitamin D can result in osteomyelitis. Okay, now when serum calcium levels are lower, okay, parathyroid, put that thing, secretion increases and stimulates bone to promote osteoclastic activity and release calcium to the blood. So I want you to remember osteoclastic are the type of cells. Osteo, and there comes a Z. Osteoclastic is osteo C cat. C means cat. That's the way I remember. So the osteoclastic cells, the C, are cutting, are breaking down the cells to release calcium. Okay. PTH, put that thing, reduces the renal excretion of calcium, okay, and facilitates the absorption from the intestine. So if I have low calcium in the serum and I order, PTH orders to reduce, put that thing, first of all, the PTH is put that thing, right? So the PTH is telling the bone, release calcium. But in order to have good amount of calcium in the serum, the PTH has to reduce the renal excretion. They need to maintain calcium in the serum by reducing the renal excretion of calcium and facilitate its absorption from the intestine. Okay, while PTH reduces renal excretion, calcitonin is going to increase renal excretion. Okay, so then let me check here. Okay, I want you to see this video so you can understand more some other concepts that are crucial, because in the next few minutes we're going to see this.
Bone is a dynamic tissue that is continually being built, broken down, and rebuilt in a process called bone remodeling. Bone tissue is broken down and resorbed by multinucleated cells known as osteoclasts. These cells are derived from monocytes which originate within bone marrow. Osteoclasts play an important role in liberating minerals and other molecules stored within the bone matrix. Bone tissue serves as a repository for vital minerals including calcium phosphate and various biologically active molecules, such as growth factors. The release of calcium from the bone can play a role in maintaining its homeostasis within the body. The cells responsible for building new bone tissue are known as osteoblasts. Osteoblasts are thought to be derived from cells found to be associated with blood vessels. Once active, they start to produce the organic component of bone, osteoid, which is predominantly made of collagen. Minerals start to crystallize around the collagen scaffold to form hydroxyapatite, the major inorganic constituent of bone, which contains calcium phosphate. Bone mineral density, or BMD, can be used to estimate the strength of bone and to assess the risk of fracture. As osteoblasts form new bone tissue, many become embedded within the matrix and differentiate into osteocytes. The structure, composition, and cellular processes that occur within bone allow it to simultaneously serve as a calcium reservoir, while providing structural support for the vital organs and for locomotion.
So as you see, guys, in order to have healthy bones and to maintain the balance of calcium and phosphorus in the serum, there are too many participants. We have the osteoblast, osteo B as birth. Okay, so they are the baby cells, birth. They are giving birth, osteoblast. That's the way you remember. The Harvation system is the tubules with veins and artery, and those nutrients are going to help the osteoblast to give birth to healthy cells in the bones, while the osteoclast is the C as cat, osteoclast, are going to break down the cells, and I'm going to release minerals in the body for the serum to be have an equilibrium between calcium and phosphorus. Okay, it's that simple. On top of that, another participants that are going to support this equilibrium is going to be calcitonin and PTH. Calcitonin, calcium to non-increase, and PTH, put that calcium in. Okay, that's the way you're going to remember it. These two are going to be crucial when you get to study endocrine. Okay, so in the next semester. So at least right now you are getting introduced and to the understanding of this process. Adrenal glucocorticoids regulate protein metabolism either by increasing or decreasing catabolism. A catabolism is the breakdown of complex molecules in living organisms to form simple ones, okay? So to reduce or intensify the organic matrix of bone. They also aid in regulating intestinal calcium and phosphorus absorption. Estrogens stimulate osteoblastic activity. Estrogens stimulate the birth of new cells, osteoblastic birth activity, and inhibit PTH. So I'm giving birth new cells, but I want you to stop the placement of calcium into the serum. I don't want you to do the put that thing yet. I want you to let those new cells to develop and mature in the bone, right? When estrogen levels decline at menopause, women, meaning when estrogen level declines at menopause, are going to be less osteoblastic, less new cells in the bone. Women are susceptible to low serum calcium levels, of course, and increased bone loss osteoporosis because we don't have that many osteoblastic activity. Androgens such as testosterone in men promote anabolism, body tissue building, and increase body bone mass. And here you have an image of the synovial joint. Also, let me mention thyroxine T4 is one of the principal hormones secreted by the thyroid gland. Yes, its primary function is to increase the rate of protein synthesis in all type of tissues, including bone. Insulin works together with growth hormone to build and maintain healthy bone tissue. Let me review this again. Thyroxine T4 is one of the principal hormones secreted by the thyroid gland. Its primary function is to increase the rate of protein synthesis in all type of tissue, including bone. Its primary function is to increase the rate of protein synthesis in all types of tissue, including bone. Now, insulin works together with growth hormone to build and maintain healthy bone tissue. Think about your diabetic patients right now. Okay, what is this? What consequence can have this insulin and thyroxine, the insulin in diabetics, and thyroxine T4 in patients that are having hypothyroidism? They are not able to maintain this protein synthesis for healthy for healthy for a good health in general, right? Joints. A joint is a space in which two or more bones come together. Okay, the major function of a joint is to provide movement and flexibility in the body. There are three types of joints in the body. We have the synarthrodial, which means that is together, is a bone together, a completely immovable joints, for example, in the cranium, that is synarthrodial. The prefix syn means together, okay? Then you have the amphiarthrodial or slightly movable joints in the pelvis, okay? And these are arthrodial or freely movable, the elbow and the knee. The disarthrodial or synovial joint is the most common type of joint in the body. Synovial joints are the only type lined with synovium, a membrane that secretes synovial fluid for lubrication and shock absorption. So articular cartilage consists of a collagen fiber matrix impregnated with a complex ground substance. Patient with arthritis, which is joint inflammation, often has synovitis, synovial inflammation, and breakdown of the cartilage. Bursae, small sacs lined with synovial membrane, are located at joints and bony premises to prevent friction between bone and structures next to the bone. These structures can also become inflamed, causing painful bursitis. And let me see. Here we have the synovium. If you can see here, the joint capsule is the one in the light blue, and the joint cavity here, the auricular cartilage, is at the end of the bone. So you have the articular cartilage, and then you have the subchondral bone plate. So always below the cartilage is going to be a bone plate. And then the one that are protecting those structures is called the joint cavity and the synovium and the joint capsule. Okay, very good. So let's continue with that. Synovial joints are described by their anatomy. And for example, ball and socket joints are the shoulder and hip, permitting movement in any direction. The shoulder and hip, okay, ball and socket. The hinge joint are going to be the elbow, allow motion in one plane, flexion and extension. The knee is often classified as hinge joint, but it rotates slightly as well as flexes and extends. It is best described as the condylar type of synovial. So let's watch a video about bursitis. This is very important. You're going to come across to this in many health settings.
Bursitis is inflammation of the bursa. Bursas are small fluid sacs in the body where two things rub. For example, when a tendon rubs near a bone, you have a bursa. Those can get inflamed. Also, it appears in areas where skin rubs against a bone or a tendon as well. We can get bursitis in multiple locations in our body. Shoulder, the elbow, knee, hip, almost anywhere. Sometimes they get inflamed. And why do they get inflamed? It's because maybe you overused it, maybe you overstrained, maybe you bumped it against something. It's very common and very treatable. Most people can solve bursitis by just doing the basics, resting the area, putting ice on the area, applying compression like a wrap around your knee or your elbow, and elevating the area. You can also try anti-inflammatories like ibuprofen or Aleve, and that can help you. If that doesn't work, a doctor can see you and maybe give you an injection or prescribe therapy. It's very easy to treat bursitis, and most of the time it never needs surgery. So if you have any concerns about having bursitis, come on in to see us and we'll help you through that.
Thank you so much, doctor. So he mentioned a protocol that is called RICE. Okay, so what is RICE? We're going to see it later, but I want to give you information about this. RICE stands for rest, ice, compression, and elevation. Rest, ice, compression, and elevation. And that's very common protocol for treating this type of inflammations. Now, in this edition, we are having we are not having many information about the type of rotation that the muscular system is able to do. So I'm gonna play another video, and that is going to simplify and is going to basically supplement whatever is missing in this edition. Okay, let's go.
The muscular system is made up of over 600 muscles. While we won't be covering all 600 individual muscles in this overview video, we will be discussing the main functions of the muscular system, the 5 major properties, the 5 types of muscle movements, 3 types of muscles, and how all of this works together to make up what we know as the muscular system. The primary purpose for the muscular system is to provide movement for the body. Now, these muscles receive their ability to move through the nervous system. There are 5 major properties to the muscular system. Number 1, muscles are excitable or irritable. This means that they are capable of receiving stimulation and responding to stimulation from the nerves. 2, they are contractible. After receiving stimulation, they are capable of contracting or shortening. Being extensible means a muscle can be stretched without damage by the application of force. With elasticity, a muscle is able to return to its original resting shape and length after being extended or contracted. The muscular system is adaptable in that it can be changed in response to how it is used. For example, a muscle will enlarge or undergo hypertrophy with increased work. But on the other hand, it can go into atrophy or waste away if deprived of work. Now, let's look at the 5 types of muscle movements. Number 1, adduction. Adduction is the moving of a body part toward the midline of the body. Abduction is moving a body part away from the body.
The reason I'm playing this video is because when you're going to work in rehab unit and there is a patient with hip replacement and you are doing the post-care, the doctor is gonna give you precise instructions. So it's gonna tell you the patient must be in the abduction position all the times. Please prevent adduction, okay? Because you don't want the hip to be misled.
Flexion means bending a joint to decrease the angle between 2 bones or 2 body parts. Extension is straightening and extending of the joint to increase the angle between 2 bones or body parts.
Also, if a patient is having a knee replacement, these instructions are going to cover flexion and extension activities.
And lastly, rotation involves moving a body part around an axis.
If a patient is getting breast surgery and they are removing the breast, So they are going to give you instructions to avoid rotation of the extremity related to that breast that had surgery.
The muscular system is divided into 3 main types of muscles, and each of these types can be moved by one of 2 ways, either voluntary or involuntary. The cardiac muscle is an involuntary muscle, meaning it operates without any conscious control. These muscles form the walls of the heart and contracts to circulate the blood. The visceral or smooth muscles are also considered involuntary. These muscles are found in organs or organ systems such as the digestive or respiratory system. And the third type of muscle is the skeletal muscle. These are what we typically think of when talking about muscles. These muscles attach to the skeleton and provide the skeleton with the ability to move. The skeletal muscles are classified as voluntary. This is because we have to make a conscious effort or decision to make them move. Although muscles obviously make up the muscle system, there are still some supportive structures that we need to look at that are also a necessary part of the system. Tendons and fascia are important supportive structures for the skeletal muscles. Simply put, tendons are what attach a muscle to a bone, and fascia connects muscles to other muscles. Tendons and fascia work together with muscles, which create the muscular system necessary for movement. While not technically part of the same system, the nervous system is intrinsically connected to the muscular system of the body. It is essential to the voluntary skeletal muscles. If the communication from the nervous system is severed from the skeletal muscles will not be able to produce movement for the body. The body is now in a state of paralysis. This is known as quadriplegia. The only organ that is not directly dependent upon the nervous system is the cardiac or heart muscle. Now there is so much more to discuss about the muscular system, but that's as far as we'll go in this introductory video.
Thank you so much for this introductory video. So this is basically covering whatever is different in this edition versus the previous edition. So we spoke about the most important. The main function of a skeletal muscle is movement of the body and its parts when bones, joints, and supporting structures are adversely affected by injury or disease. The adjacent muscle tissue is often involved limiting mobility. During the aging process, muscle fibers decrease in size and number, even in well-conditioned adults. Muscle atrophy results from muscles are not regularly exercised and they deteriorate from disuse or aging. Supporting structures for the muscle system are very susceptible to injury. They include tendons, that is bands of tough fibro tissues that attach muscles to bones. Tendons attach muscles to bones, and ligaments, which attach bones to other bones at joints. So the way I remember this is, do you remember Temu, which is the competition of Amazon right now? So it's Temu ball, tendons, muscle, bones, and volleyball. So it's bones, ligaments, bones. Temu ball and volleyball. Okay, there's no way you can miss it that way. Musculoskeletal changes associated with aging, osteopenia, this is a concept you need to remember, or decreased bone density, bone loss. We so far learned osteomalacia, which is the soft bone as a consequence of low vitamin D. Osteomalacia, low vitamin D, causes soft bone tissue. Then we have osteopenia, a decrease in bone density, which is bone loss. Many older adults, especially thin white women, have severe osteopenia, a disease called osteoporosis. Severe osteopenia is a disease called osteoporosis. In other words, osteopenia is the stage before osteoporosis, okay? It's like prediabetes and diabetes, okay? Osteopenia, a stage before osteoporosis, and we know that osteopenia occurs especially in white women, and we know that the race that is having a good bone density is African Americans, right? We are just doing a review. This condition can cause kyphosis. The osteoporosis can cause kyphosis, outward curvature of the thoracic spine, causing a humpback, and gait changes which predispose the person to fractures. Okay, so synovial joint cartilage can become less elastic and compressible as a person ages. Joint cartilage becomes damaged, leading to osteoarthritis. Osteoarthritis is osteo means bones, arthritis is joints, and itis is inflammation. Therefore, it's going to be the inflammation of the bones of the joints, okay? The most common joints affected are the weight-bearing joints of the hip, knee, and cervical and lumbar spine, because these are supporting a lot of weight. You know, the cervical is supporting, believe it or not, a lot of weight, and the lumbar. Professor, why the cervical? The cervical is only below the head. Yeah, but the cervical in certain way is affected by the movement of the lumbar. There are many patients that are doing their walking, they are doing their running, jogging, and basically you may think they are only exercising the lumbar spine, but not. The way they position the head, the way when they are running, they are moving the arms is causing an effect on the cervical. So those four, lumbar, cervical, hip, and knee, are supporting a lot of weight. In older adults, musculoskeletal changes can cause decreased coordination, loss of muscle strength, gait changes, and a risk for fall with injury. Okay, so let's review these changes in the musculoskeletal system related to aging. We have decreased bone density. We spoke about that after 35. We need to reinforce the need to exercise, especially weight-bearing exercise. Reinforce the need to exercise, especially weight-bearing exercise. And it's going to slow the bone loss. Okay, these are the rationales all the way on the right. Increase bone prominences. This is changes in the musculoskeletal system related to aging. There's going to be increased bone prominences, and we need to prevent pressure on bone prominences, right? We need to turn and position these patients if they are on bed. If they are not in bed, but they tend to be seated for long periods of time, we need to promote walking or movement, okay, to avoid skin breakdown. Kyphosis and white-neck gait shift in the center of gravity, which could cause imbalance and falls. We need to teach proper body mechanics, instruct the patient to sit in supporting chair with arms. There are different devices that can help you keep your spine straight, right? Let me see. Okay, let's watch this video about kyphosis. Let's watch this.
Positions. The vertebrae of a healthy spine are shaped like cylinders and are stacked one on top of another. Kyphosis occurs when the bones in the thoracic region of the spine become shaped like wedges.
This condition can be caused by different problems and diseases. Osteoporosis, which commonly occurs in postmenopausal women, can cause compression fractures of the vertebrae that can then lead to kyphosis. The intervertebral discs, found between the vertebrae, act like shock absorbers. Disc degeneration due to aging can cause kyphosis, as the discs dry out and shrink. Kyphosis of unknown etiology, which begins in adolescence before puberty, is called Scheuermann's disease. It is more common in boys and continues to worsen with age. Cancer or metastatic processes in the vertebrae can cause severe deformities that may result in kyphosis. Postural kyphosis most commonly occurs in teenagers due to unhealthy sitting positions.
Nurses that are studying, we are in high risk to develop kyphosis if we are not sitting in a proper position. Okay, now if I tell you in very technical words that kyphosis could be caused during menopausal periods due to the lack of estrogen and the lack of creation of osteoblasts, right? Now you understand, because estrogen creates osteoblasts, the baby new cells that forms the bone. If we don't have this, there is a risk for osteoporosis in menopause women, as we saw before. Okay, that's why I take my time, I put videos, I explain so you can understand. You see a patient that is coming 50, 54 years old entering, white descendant, you're going to think osteoporosis because it's white. You're going to see menopause, estrogen is decreased, you're going to think about osteoporosis. And it's 54. If that person is telling you that he's teaching or he's studying or he's working in telemedicine, you are going to think about hyposis, you're going to think about improper position right there, just by seeing the patient. Okay. Okay, let's continue. So, joint cartilage degeneration, osteoarthritis. Remember, we are talking about changes in the musculoskeletal system related to aging. Joint cartilage degeneration or osteoarthritis. You need to provide moist heat, such as shower or warm, moist compressor or heating pad. Now the white base gait occurs due to myelopathy and neurological disorders. This gait disturbance is described as clumsy, staggering movement. Myelopathy is a condition in the muscles, myelopathy. Okay. Okay, decreased range of motion. You need to assess the patient ability to perform ADLs, muscle atrophy, decreased strength, teach isometric and isotonic exercises. I have provided in the supplemental file a video here, okay, types of muscle contractions, all the isometric and isotonic exercises that you can suggest your patient after evaluation of the range of motion. You don't want to give these exercises if the patient is having any problem with movement, okay? And you can see this video, you can watch this video. Health promotion, disease prevention. So that's good to know. Falls occur when older adults have inadequate calcium and vitamin D because they are at risk for osteopenia and osteoporosis. So when we see a patient, okay, and we want to prevent falls, first thing you're gonna do is you're gonna observe, you're gonna check the blood levels, the calcium levels, phosphorus levels, and vitamin D. Women may slow the process of bone loss by taking vitamin D and calcium supplements and increasing this nutrient in their diet. Weight bearing exercises such as walking and straightened exercises can reduce risk factors for osteoporosis and maintain muscle strength. Young men are at the greatest risk for traumatic injury related to motor vehicle and scooter crashes, and should use these devices safely and avoid substance abuse. Young and middle-aged adults tend to encourage more than other groups in high-impact sports such as excessive jogging or running. Older adults are the greater risk for falls that result in fractures and soft tissue injury. Tobacco smoking can slow bone healing. Excessive alcohol intake can decrease vitamins and nutrients that the person needs for bone and muscle tissue growth. So that's good to know. Also, many health problems in the musculoskeletal system can be prevented through health promotion strategies and avoidance of risky lifestyle behavior to prevent injury and disease. So now we're going to stop here. We're going to take a break, and then when we come back, part 2 of this chapter, and we're going to get deep into the assessment part. Thank you.